transplant surgery performed at least 5 years back and now, today, are there any changes, major changes?
The liver transplantation procedure
the
is
safety profile, or maybe success profile, maybe finance profile?
Finance profile is almost the same.
Yeah.
Safety profile, it's more safe now because we have lot of gadgets.
Yeah.
You know, we don't compromise on anything.
Yeah.
I mean, even though it costs, the institutions put up
their
things
money to get
make the patient safe. And we have a very good system at HCG, wherein we have everything that a transplantation unit requires.
No, why I ask you this question means you can say that here you can choose the younger doctor, because otherwise we have a feeling that okay, older the doctor is better. But since the newer technology is more of you are more friendlier with the newer technology, it is better and safer to be with the newer hands. Okay, Dr. Jagannath Dixit is with us, and he is going to talk about minimal invasive surgery in colorectal cancer. So आमच्याकडे आशिल्ले डॉक्टर तांच्यांनी एक महत्वाची गोष्ट सांगली की आज लिव्हर ट्रान्सप्लांट सेफ असा, तर खूपसो फायदो असा, पेशंट बरो जावन घरा वचूं शकता, 3 दिसांनी बरो जावं शकता. जरी ते मातशे कॉस्टली अफेअर असले तरी सुद्धा जीव वाचोवपा खातीर म्हाका दिसता पीपल हॅव टू सॅक्रिफायस समथींग, बिकॉज देर आर सम पीपल म्हणजे जे लोक सोरो पिताले किंवा केन्ना सोरो पिनासतना सुद्धा तांकां कॅन्सर जावं शकता. ताचें एक कारण म्हणजे डॉक्टरान सांगलें की डायबिटीज किंवा हे जे आमचे बाकीचे डिजीजीस असता ते जशे पयलीं जर वॅक्सिनेशन करूं ना जाल्यार ही दुयेंसां मागीर लिव्हराक अफेक्ट करता. आणि 40 वर्सां उपरांतलो किंवा 50 वर्सां उपरांतलो जो पेशंट डायबिटीक आसा तांच्यांनी 6 म्हयन्यांनी आपले अल्ट्रासाउंड करून घेवप खूब गरजेचें आसा. सो आतां आमी डॉक्टर दीक्षिता कडेन वचुया.
Earlier they used to tell that bigger the incision, the bigger the result, and the
better is the surgeon.
Famous is the surgeon.
Yeah.
Now it is not so.
Yeah.
In oncology, what we have to the same it is something like the same amount of quantum of surgery is done without compromising the overall outcome.
Correct.
So that is the basis for in the treatment of cancer. In minimally invasive surgery, we are not violating the normal tissues. So for removal of any colonic tumor or rectal tumor, we make an incision and we go through normal area and reach the tumor and take out the tumor. So in the case of keyhole surgery or the laparoscopic or the robotic surgery, we make a incision, a small incision, and put the camera and visualize the entire area. So there are about 5% of the time, most of the time the PET CTs or CT scan MRI could have not picked up a small microscopic disease. So this we can pick up through the laparoscope, and we can take some more biopsies, and then we can judge whether it should be go for surgery or not. So in the process of diagnosis, this minimal invasive surgery has got a very greatest requirement. And coming to the therapeutic, that is the treatment aspect. With the minimally invasive surgery, there is a lot of patient advantages. Okay, similarly, when when we start treating the patient, there is an advantage for the doctors with a improvement in the learning curve. Okay. The only disadvantage I want to tell you is that only the duration of surgery. It has to be preferably done with the general anesthesia, and where the duration of surgery to achieve that result, we need to struggle little bit. Yeah. But greatest advantage for the patient, basically the less amount of pain, and you are not using much of narcotics, especially opioid drugs and other things, and the early starting of the oral feeds, that is another advantage, and early ambulation, patient can start walking, and then we can discharge the patient early, and less chances for the infection also. There is no big scar, and the patient can ambulate and go home early, and these are the advantages of laparoscopy. And added to that, there is one more advancement called robotic surgery. As we go down into the pelvis, and there are important bony landmarks, there are some rigid structures, we cannot expand that, especially the low rectal cancers. And these cancer, the robot has got a 360-degree rotation, and where we can reach down into the pelvis and start suturing this. So there are some fixed structures like uterus or the rectum, and these specific areas we can plan for a robotic surgery.
I see.
But a good laparoscopic surgery can also give the almost near equal results as robotic surgery. Robotic is just having some better car, like comparing Mercedes versus BMW car. It is, but we are driving in a four-wheeler.
Yeah.
So it's a, you know, it is a added advantage to the patient. But you know, the important things that there is a, you know, basic concept that we should not compromise the oncological outcome. So the major advantages are of laparoscopy is that you are having a great magnification and you are seeing the small vessels and the nerves. So these structures can be preserved completely. So if we preserve these structures, there will be a better you know, outcome, like urinary dysfunction will be less, sexual dysfunction will be less, and you know, you can go in a proper anatomical plane.
Achha.
In
fact, you can reach wherever you want.
Yes, exactly. So we can go up to the pelvic floor and dissect it and see under magnification. So these are the added advantages. But for the extraction of the specimen, we need to have some you know, area where we have to make a normal area and try to extract it out.
Yeah.
So, but there are some reports of like port site metastasis, that when we put the port, there can be a dissemination of the cancer coming into the, but that's all about 1 to 2% chances. But if we do some you know, a safe procedure following the some of the principle, like extraction of the organ, retrieval of organ we call it as, we use some sort of a artificially made polythene bag. Once we resect the tumor, we'll put it into the container and we'll extract it out without touching the scar. So the less chance of port site metastasis. And another great advantage is that we can, with the help of energy sources, especially we have got a harmonic and we have got a sonicision and some of the other electrocauteries. Now the other companies have come out with Olympus, Thunderbeat and all that. So these you know, energy sources are you know, the right hand for the surgeon. Without energy source, we cannot go and this one, because we don't want to put a stitch and take a bites, and then it will prolong the surgery also. And we have got a multiple liga clips and all that, where any bleeding, suddenly we can attack that area and try to control the area and try to seal off some of the lymphatic channels and other things. So by improvement in the technology and advancement, you know, our the surgery safety has gone up. And whenever patient comes and asks, we don't tell that this will cause this problem and this will cause. So the morbidities of surgery as such are less, and complications similarly with anesthesia results are also safe. But there are some specific condition where we cannot do laparoscopy or this one. So basically a previously operated patient and where there are multiple additions and no anatomical plane, or the plane has totally gone, and the extensive spread of the cancer.
Achha. So definitely where you have to go for open surgery.
Yeah, these are the areas where you can, you know, once we to reach the site of our surgery, it requires about 1 or 2 hours. So always there is what is called conversion from laparoscopic to the open procedure. So a safe surgeon is a one who, if he is able to do comfortably without causing any morbidity, then you know, we should proceed. Or if there is any this one problem, I think better to open and do that. And another thing, advantage, the amount of blood transfusion have come down drastically. Earlier we used to give about 2 or 3 units of blood loss on the table during surgery, immediately post-op, and all that has been stopped. Now we don't give the blood transfusion. The blood and blood product usage has come down, and the selected cases, if there is any fall in blood pressure or any other things, and to correct only the red cells, we give the blood transfusion. Otherwise, you know, the overall it has considered one of the safe surgeries.
So a good surgeon has to decide on table as per the requirement, rather than sticking to his ego, saying that okay, I have promised the patient that I will do a keyhole surgery and I will stick to that. So I think that is one of the good, you said, like with experience people have to learn also. And second thing, what I have to, does the obesity counts?
Yes, exactly. See, basically you must have heard about a lot of bariatric surgeries where all these patients are obese, but still the laparoscopy, minimal invasive surgery, can be done safely. Obesity as such is not a contraindication. It is probably one of the things that excess of fat in the intra-abdominal coverings, especially, and we don't know where the vessels are running, where the nerves are running. This is only the problem what we face, but as such it is not a contraindication for doing surgery.
अच्छा. सो दोतोरान सांगले की आज ही जी मिनिमल इन्वेजिव्ह सर्जरी आसा, म्हणजे ल्हान बुराकांतल्यान सर्जरी करप ही खूप सेफ जाल्या, पेशंटाकूय खूप फायदो जाता, पेशंट बेगीन बरो जाता आणि त्याचा खूप फायदो म्हणजे जो एक्सपर्ट हँड आसता तो ते सक्सेसफुली करू शकता. तर हाचो एक असो आसा की पेशंट बेगीन बरो जाता, ताका म्हणजे खर्चय चड येना. दॅट इज वन ऑफ द गुड थिंग. आणि जे एक्सपर्ट हँड्स आसता म्हणजे इन गुड हॉस्पिटल्स ते सक्सेसफुली हे ट्रीटमेंट करू शकतात. सो अकॉर्डिंग टू यू इवन द कॅन्सर सर्जरी हॅज बिकम सेफर दिस डेज.
Yes.
Correct?
Yes.
So I would like to ask you same question. 5 years back, same surgery, and now, what are the changes? What do you think? What has been changed according to you?
Nowadays, most of the youngsters are, they are getting trained towards the minimal invasive surgery, and we have got a, fixed already trials have been made. There is a color study and atlas studies, and then comparing the open versus the laparoscopic procedures, and comparing the open with the hand assisted laparoscopic procedures, and all this have shown that there are specific advantages. When there are advantages with changing pace of our life, we have to change with the technology. Otherwise we will become a senile, and then we will not able to march with the growing technology and techniques.
Okay, I think, sir, I'll ask a very simple specific question. Take home message within 10-15 seconds.
For any cancer, the real take home message will be prevention.
Yeah.
Because once cancer comes, it is very difficult to treat it.
Yeah.
And even if you cure it, it will be at a very great cost.
Yes.
Both for the cost of money, as far as money is concerned, and physical loss of some structure, and the painful stay in the hospital as well as at home.
Yes.
So if it is possible to prevent, I think it has to be prevented. If that is not possible, early detection and curing with a minimal treatment, and if that is also not possible, then right treatment for the stage of the disease.
Correct. That's most important. Sir,
I've spoken about liver transplantation. I mean, I do surgeries of the liver as well. Why I'm putting up this? With advancing treatment from medical oncology side and good surgical techniques for the primary cancer, patients are living more and more.
Correct.
Especially colorectal cancer. And these patients at certain stage on follow-up. Why I mentioned follow-up is very important.
Correct.
And then these patients on follow-up will be found to have liver metastasis. And it is very safe to resect these, and patients are cured. We have cured patients with up to 70% of the liver occupied with liver metastasis.
Oh.
And then that patient is still living, doing fantastic. Okay. And we can do the resection again and prolong the life.
Oh, that's another very important. म्हणजे आज लिव्हर ट्रान्सप्लांटाक सुद्धा म्हणजे लिव्हरान जे मेटास्टासिस झाले ते पेशंट सुद्धा सर्जिकल ऑपरेटिव्ह चेंजेस करून बरे जाऊ शकता. हे इम्पॉर्टंट. येस सर. Take home message.
Especially, regarding the sphincter preservation surgery for a rectal cancer, nowadays the preservation has gone up with the improvement in neoadjuvant chemotherapy and radiation. We don't do a permanent colostomies. We can conserve the sphincter and do some temporary ileostomy and get away the things. So as the things advance, the early lesions most of the time, and early and locally advanced, all this the surgery followed by the chemotherapy gives almost the equal result. But as we go down into the pelvis, we have to be more worried about the local recurrence. So I think in early detection gives the best results, and the combined modality of treatment gives the best result.
Thank you. आयच्या गजालीच्या निमतान आमच्या बरोबर सामके 3 नामनेचे बेंगलोरचे डॉक्टर्स आशिल्ले. दे हॅव रियली शेअर्ड गुड एक्सपिरियन्स. म्हणजे जे आमच्या खातीर म्हणजे लर्निंग प्रोसेस, त्याचप्रमाणे आमचे जे पळोवपी आसा तांच्या खातीर खूप महत्वाची माहिती तांणी दिली. तुमच्या सगळ्यांच्या वतीन तशेंच प्रुडेंट मिडियाच्या वतीन तुमकां सगळ्यांक आदान संदेव बरी करूं. नमस्कार.